Amitabh. Uh, a very warm welcome to our press, the people who have come here today to be a part of our journey for launching the fatty liver clinic at Apollo Multispeciality Hospitals. At the outset, I would like to thank you all for coming here. Apollo Multispeciality Hospitals, Calcutta stands tall in the eastern region, and this is because of what our people do, what our chairman, Sri Pratap C. Reddy, has always visioned. His new vision for Apollo family is to touch 1 billion lives. Our mission has been to bring world-class technology, healthcare to the people of the country. This international class may be technology, maybe an idea, a vision, or a focus onto some things. So today, what we bring to you may be considered as a focus. Dr. Pratap Reddy has always mentioned that it is the non-communicable disease which will take over a large population, and that is one of the reasons why Dr. Goenka and his team have brought together a focus on an idea, on an existing group of parameters to catch the disease early and prevent morbidity and mortality among the people. It's the first fatty liver clinic which brings focus in the entire Eastern India, and we bring to you today a small walkthrough by Dr. Akash on the disease, what Dr. Goenka and his team wants to bring to people of Calcutta and to the Eastern India. After the talk, we'll also request Dr. Goenka to summarize the event and throw his light on certain important features. So before we go, I'll request Dr. Akash to please come in. Thank you again for coming here. Welcome, and we hope that we live up to the expectations and the challenges of this disease. Over to Akash.
Afternoon to everybody assembled. For the next around 10 minutes, I would like to walk everybody through towards this global problem that is facing us, the challenges that's facing us today, how big the magnitude of the problem is, and how we can formulate strategies to tackle this in the long run. So what is non-alcoholic fatty liver disease? In a very simplistic term, it refers to the accumulation or presence of fat in the liver. That fat can be seen by ultrasounds, which is a very common thing that's done almost for everybody for some reason or the other, or it can be seen by somebody who undergoes a biopsy. But the essential core of it is there has to be some degree of fat. But fat can also be there due to some other causes. People who consume alcohol in a significant amount, which is defined by different ranges for male as well as females, they tend to have fat. People who are on medicines like steroids, they also tend to have fat. People who have genetic disorders, they also tend to have fat. So when you exclude the presence of all these entities, what you're left out with is this entire spectrum of disease called non-alcoholic fatty liver disease. This disease has got 3 cardinal associations, which we all are very familiar about. Number 1, obesity. Number 2, diabetes. And number 3, cholesterol issues, which we scientifically call as dyslipidemia. And this has got 3 subtypes. 1, you have got people who are obese. They can have non-alcoholic fatty liver disease. But this disease can also be seen who are not obese. So you can either be lean, which is called as lean non-alcoholic fatty liver disease, or you can be somewhere in between lean and obese, which we call as overweight non-alcoholic fatty liver disease. So if you look back at this entity, it is sort of a reflection of some of the diseases which are very familiar with. We are all very familiar with diabetes, we are all very familiar with hypertension, of cardiovascular disease, cholesterol issues. But somehow in this race, this liver part of it, which is sort of a hepatic or a liver manifestation of this entire spectrum, what we call as metabolic syndrome, this got left behind. We forgot to keep an attention to those LFTs which somewhere got left out. Not only this disease has this classical associations of these entities, there are lots of emerging diseases ranging from kidney disease, weak bones, polycystic ovarian disease, sleep apneas, and a wide variety of cancers which have gradually been shown to be associated with this disease. It's a disease which spreads across a continuum. If you have a worldwide survey, if you take the entire global population altogether, around 25% would be having fatty liver disease. That's a huge number. Out of which, of those 25%, you'll again have 20 to 25% in which this fat starts to behave in an abnormal manner. And when that behaves in an abnormal manner, it is called something as inflammation, which we refer to as steatohepatitis or NASH in a short form. And out of these, again, 10 to 15% progresses to something called cirrhosis. So if you take the entire population and out of them 25% have NAFLD, just imagine the numbers will ultimately land up having cirrhosis from this disease. So if you see the prevalence globally, there are wide variations in prevalence that are there. Scary for us is that we fall in one of the highest prevalent countries for non-alcoholic fatty liver disease, going upwards of 25%, falling completely in the red zone for fatty liver. So let's go back to those two diseases which we are more familiar with. Diabetes. So if you take people with diabetes, upwards of 70 to 75% of patients with diabetes have fatty liver. And then the bad variety of it that we talked about is the NASH. Again, more than 25% would be having non-alcoholic steatohepatitis. And the same story folds out with obesity. So if you club them together, you can have an idea that 3 out of 4 of any patient who has got obesity or diabetes would be having non-alcoholic fatty liver disease, and 1 out of 4 would be having the bad variant, which is called as non-alcoholic steatohepatitis, out of which a major fraction would be progressing towards cirrhosis. So what's the story from India? The story from India is very gloomy. If you see on a community level, it starts at 28%. But if you go to an overall populations, it's upwards of 35%. And specifically, if you look at those people who have got risk factors like diabetes, like obesity, it's more than 50% of the population of these specific population which has non-alcoholic fatty liver disease. And the last thing to worry about is our next generation, the children. Obesity has become such a big problem in children. If you take those obese children, more than 60% of those children have non-alcoholic fatty liver disease. So we try to translate this into what we see in our daily experience at Apollo. We just took a small time period between March to July, where about 720 patients, and what we found out is that 35% of all these are non-alcoholic fatty liver disease. And the story doesn't end there. If you see the other fractions that is there, is those patients who have already developed cirrhosis. Again, a majority of those patients would also be due to non-alcoholic fatty liver disease that was never detected. And if somebody has hepatitis B or hepatitis C, that doesn't stop them from having fatty liver disease. So if you club the entire thing, what we see in liver patients is 50% as of today is all non-alcoholic fatty liver disease. So how do you approach this disease? In a very simplistic manner, because it's such a widely prevalent disease, you can't go on and tackling every person with this disease. So we need to find out the patients or the subgroups in which the disease is severe, assess it as how severe is it, and then decide what should be the treatments and how those treatments are to be followed up. A word to remember is that every patient of non-alcoholic fatty liver disease deserves a treatment. The issue is we sometimes think that treatment only needs medications. Non-alcoholic fatty liver disease is a disease of lifestyle, and the treatment starts with lifestyle modifications. So this is how we generally approach in a simplistic manner of any patient of non-alcoholic fatty liver disease. There are two things. Number one, you look at the fat, and number two, you look at what sort of damage that fat has caused to the liver, which we call as fibrosis, which simplistically means that how hard your liver has become. The fat can be assessed by multiple things, out of which the commonest is an ultrasound, and there are other parameters which we routinely use, and we at Apollo hospitals happen to have the best modality for fat assessment as of today globally, which is MRPDFF, which has been globally validated as the best assessment beyond a biopsy. Similarly, for assessment of fibrosis, you can do it with blood tests, which are little inferior, and then there are higher end tests, which again we happen to have one of the globally best validated tests, that is MR elastography. So why are we so much worried about this non-alcoholic fatty liver disease? We saw the prevalence, but does that prevalence translate into mortality? This is what this figure shows, that if you don't have fatty liver disease, you can die of many causes. You can die of heart attacks, you can die of strokes, you can die of cancer. But once you start having fatty liver disease, not only you start to have a new cause of death, which is liver-related problems of liver cirrhosis, but your death due to the other causes of cardiovascular events, of strokes, of heart attack also increases manifold. So any presence of non-alcoholic fatty liver disease increases both your liver-related mortality as well as your all-cause mortality. So this is how any patient, as I was referring to, that management of non-alcoholic fatty liver disease is not only drugs. It starts with a lifestyle, because it is a lifestyle disorder. 4 key principles that are there. Number 1 is change your caloric intake, or restrict your caloric intake, which can be by fractions of 30% to start with, and which translates basically into around 750 to 1000 kilocalories of diet restriction. Fundamental aspect is that you have to reduce your caloric intake. Your expenditure has to be more than your intake is, and that has to be supplemented with exercise, which can be any type of exercise. People who are into cardio, they can do their cardio. Who are not able to do a cardio, they can have other sorts of exercise. Even simple exercises, who are having difficulties to walk, even a brisk walking for around 30 to 40 minutes per day, that also would lead to some degree of utilization of energies. So what these two things do, restriction of diet and exercise, leads you to lose weight. And when you lose weight, you reverse fatty liver. You not only reverse your fat, even if somebody has developed fibrosis, has gone into an ahead stage, if you happen to lose 10%, that means somebody who is 80 kgs, you lose 8 kgs, you can still reverse that stage. But you have to tackle that at that stage when it's reversible. If you go and reach the stage when it's irreversible, then these things don't tend to work. That's the entire idea of promoting awareness of this disease, so that you can still tackle them at a situation where this entire reversal can be brought about. 2 things which have been debatable in non-alcoholic fatty liver disease. Number 1 is coffee, which has been shown to sort of provide a beneficial effect worldwide across many studies. So a fatty liver disease prescription now comes with 2 to 3 cups of black coffee without sugar every day. That would be a part of many fatty liver disease prescriptions. What about alcohol? Many people have an idea that 1 to 2 glasses of alcohol is perhaps fine, it's cardioprotective, it's fine, I can do with it. If there is presence of any degree of liver abnormality, then alcohol is a strict rule. In patients who have got fatty liver disease and a tendency to progress, any alcohol is bad for you. This, once you have achieved all these restrictions and modifications, then comes in the treatments with pharmacotherapy. And we are having, this is the area which is changing very fast with fatty liver disease. We are getting newer and newer drugs every day. And within a few years of time, we are possibly looking ahead to an area we'll have multiple medications to use with. So, fatty liver disease is a disease which deserves a holistic management. It cannot be only tackled by specialists or subspecialists. The care has to start at the primary care, starting with awareness. There'll be lots of physicians which will be dealing, who need to understand the importance of the disease, because they are the ones who will be seeing it at a much earlier stage. And they need to follow the pathways or understand how early to make them avail the care that will help them to actually reverse this disease. multiple other specialties like endocrinology, cardiology, they all have to be a part of this disease because this is a multifactorial disease. And this is what we are aiming at today to the launch of a holistic care for any patient with non-alcoholic fatty liver disease, where you get your assessments at step 1, you get the physicians, you get the dietitians, you get the exercise counselors, you get the interdepartmental communications done so that the final benefit is towards the patient. So the message that we need or we want to convey from this and the launch of this clinic is that we have got into a habit of this liver fat, that I have fatty liver, oh everybody has it, it doesn't matter. This is what needs to change. Fatty liver is not a false alarm, it's a fire alarm. And when there is any fire alarm, you should doubt it as fast as it can. Because once it spreads, then it will be very difficult to contain. Thank you everyone. With non-alcoholic fatty liver disease, that mostly it's an asymptomatic disease. You'll hardly be having any symptoms. There are some vague symptoms which have been associated, like fatigue, like poor quality of life, as well as a vague sort of discomfort in your upper abdomen. But none of these are specific symptoms, and as such, NAFLD is an asymptomatic disease. In a center, there's nothing called liver tonics. These are all promoted by ancillary systems of medicines, which actually do no good. There's no data to say that any one of these liver tonics is of any help whatsoever. The second part is about proton pump inhibitors. You have to remember that besides fatty liver disease, India also has got a huge population or problem of what we know as GERD, or gastroesophageal reflux disease, that's the acidity disease. So per se, there has not been a proven causal association of worsening of fatty liver disease with the use of PPI. But if somebody has developed cirrhosis, there is some evidence to say that irrational use of PPI leads to problem with people with cirrhosis.
We'll take questions in some time.
Regarding kidney,
Associations of long-term use of proton pump inhibitors leading to some degree of kidney damage.
I request the guests to just hold on for a moment. Dr. Akash, if you can take your seat. We'll take questions in some time, but before that, I would request Dr. Goenka to summarize the discussion for the audience, and after that, we'll keep the floor open for questions.
Can I request Dr. Akash has given you an overview of the problem of fatty liver disease, non-alcoholic fatty liver disease, and what we intend to do in this comprehensive fatty liver clinic. Somebody asked me just before we started the program that are you doing something which was not available at Apollo earlier, and why a fatty liver clinic? Are you going to do anything new? So let me tell you that it's not that we were not treating fatty liver patients earlier also, but the idea basically to have a focused, comprehensive management of these people. And I have 4 mantras for this fatty liver clinic. The first one is educate and make them aware. That's most important, because as Dr. Akash said, people are not aware that fatty liver disease is such a common problem. If you look at the population of India, which is 130 crores, we hear this term very regularly. 1/4 at least are suffering from fatty liver disease. So 35 crore people in India are suffering from fatty liver disease. This is a rough estimate. And a small but definite percentage will progress to deadly cirrhosis. So the first thing is awareness and education. The second thing is to investigate. And this is again what Dr. Akash said, that mostly these people are asymptomatic. So you need to find out whom to investigate. One group can be those who have those metabolic syndrome group, diabetes, hypertension, obesity, dyslipidemia, polycystic ovarian disease, CKD and all. So these people should be investigated, because there is a chance that 1 in 2 out of these people would have fatty liver disease. So, and also now people do a regular health checkup. So an ultrasound and a liver function test during a routine health checkup can also pick up some fatty liver disease. So that's investigated. Once you reach a diagnosis of fatty liver disease, then we are fortunate enough in Apollo to have these advanced MRI-based technology, MRI PDFF and MR elastography, which will tell us exactly as to how much is the fat and how much is the fibrosis inside the liver. So second mantra is investigate. Third mantra is treat. And as Akash pointed out, that there are 2 components of treatment. One is lifestyle modification and number 2 is drugs. So we treat them. And as rightly pointed out, the treatment is not very difficult. You just need to lose about 10% of your body weight. 80 kg people losing about 8 kg, and I tell them that go slowly, go over a period of 5 to 6 months and lose that 8 kg, and your not only fat will be reduced, your fibrosis will also be reduced. So third is treat, and the fourth is monitor. I think once you diagnose somebody as fatty liver disease, you need to do them monitoring on a regular basis, maybe every 3 months or 6 months, to see whether they are going from fatty liver stage to steatohepatitis, to cirrhosis, and to cancer. So this is what is monitoring will be doing. So we intend that we'll be doing all the 4 components of management of fatty liver disease in our comprehensive clinic. And the idea is to have dedicated people, dedicated hours in the OPD to tackle these people, because otherwise they get lost in the rush of the patients. I think that's what, in a nutshell, I wanted to share. And between me, Dr. Bhatia, and Dr. Akash, we'll be very happy if there are more questions. Let's first, I could hear a few questions related to gastroenterology in general, but let's first talk about fatty liver disease, if there are any questions on this. Let me tell you, the fatty liver is now one of the commonest cause of end-stage liver disease and a need for liver transplantation. Not only in the Western world, but in our country also, that it is becoming a commonest indication for liver transplantation. As we are able to tackle hepatitis B and C, to some extent, I think fatty liver disease is becoming a global priority. Thank you.